So common femoral artery and common femoral vein cannulation is considered a basic skill and frequently done in the cardiac cath lab. It is the most time consuming during the pediatric catheterization. Because in infants who do the procedure under the general anesthesia, so a prolonged procedure can lead to hypothermia and respiratory depression. So keeping in mind that our aim should be to minimize the time for successful vascular access. What method we have for femoral vascular access is the anatomical method in relation to femoral head. But what we can see here is in infant femoral head is not ossified. Also, the greater trochanter is not ossified. Another limitation is that external landmark may not correspond to internal anatomy, especially in the chubby childs. Then a palpating femoral artery pulsation is the another method which can be limitation in the child with compromised hemodynamics. And the recently and the popular method is used is the ultrasound guided cannulation. It has several advantages, but the availability and expertise is not universal. So to define the course of femoral artery and common femoral vein in infants undergoing cardiac catheterization, this was my aim of the study. It is was a descriptive study from March 2020 to February 2022. We included all the infants undergoing cardiac catheterization requiring contrast guided femoral vascular access. So after putting the infants into supine position under general anesthesia, local site was cleaned and the lower limb was abducted and externally rotated by 30° for the separation of common femoral artery and common femoral vein. For the contrast injection for the profiling of common femoral vein, we put it through the peripheral vein and we profiled the common femoral vein first, then we punctured the common femoral vein, we took the catheter and crossed to the arterial side, went up to the common iliac artery and the common iliac artery was profiled, and then we arterial puncture or access was taken. One thing should be emphasized that we didn't recruited especially infants for this procedure. We did this analysis in all those patients in whom we are already doing the procedure. So no specific recruitment. According to availability of the landmarks, we drawn a line from the uppermost and medialmost part of the shaft of the femur to medialmost and lowermost end of the iliac bone, and the course of common femoral vein was assessed in relation to this line. Then the another line, line B, was drawn from the uppermost end of the femur parallel to line A, and the course of common femoral artery was analyzed in relation to this line. The another available landmark, we had the pubic ramus. So we drawn a line from the pubic ramus, and the another line parallel to this was drawn from the upper and medial end of the femur. So this created a parallelogram CDEF. Coming to more specific, again we divided this line A and line B into three parts, upper, mid and lower 1/3, and try to define the course of common femoral artery and common femoral vein in relation to this line. Another landmark we tried to define is in relation to mid-inguinal point for both the common femoral artery and common femoral vein. So we had a 16 subject due to limited admission during the COVID era and the shutdown of the cath lab. We did the procedure in 10 PDA. So we got the 10 vein plus 10 arteries and 6 balloon pulmonary valvuloplasty. So total 16 vein and 10 artery we analyzed. The age range of the children or infants was 4 to 12 months with a mean age of 9 months. So this was my observation that this is the line A, and we are trying to find the course of this common femoral vein in relation to this line A. What we can appreciate here is that this common femoral vein is almost on this line A. In another study subject, we found that this common femoral vein is lying medial to this line A. So out of 16 subject, in 14 we found this common femoral vein on line A, and in 2 subjects it was medial to line A. When we did to the parallelogram, it was same results. Then we tried to define the formation of common femoral vein, and it was found that this common femoral vein formation occur in the lower third. So coming to more specific, this middle one third of the line A, 90% of the vein was on line A, and 12% medial to line A, because the puncture site should be considered as in the middle. Now coming to the common femoral artery in relation to line B, it was medial to line B in 80% of the subject, and some part lied on the line B in 20%. Then coming to the relation with the parallelogram, it was all the common femoral artery lied within this parallelogram. So this middle one third of the line B, where we consider the puncture site, keeping in the mind that the lower puncture site can give the multiple complication. Then the common inguinal ligament in relation, all was medial to the mid-inguinal point or medial. This is the first study to define the landmark of common femoral artery and common femoral vein under fluoroscopy. So our study, we can conclude that common femoral vein cannulation should be attempted in middle third of the line B, in middle of the rectangle. The common femoral vein along line A in middle third, and all punctures should be done medial to this. And the use of existing bony landmark under fluoroscopy, especially in infant where we had got not ossified femoral head and unstable hemodynamics, this can give the fair ideas. Thank you.